At that, I would like to introduce our first speaker. It's really my pleasure to introduce Dr. Abeyasinghe. He is the coordinator for malaria, vector-borne diseases, and parasitology at WHO at Wipro in Manila in the Philippines. And was previously the director of the malaria program in Sri Lanka. So particularly in our region has a really unique perspective and understands what is needed to get to elimination. So we were very happy that he agreed to join our symposium. And I'd like to welcome him first to give his talk.
Thank you, Jamie. Let me master the technology first. And okay, we're good to go. We have it. Thank you. So I'm going to talk to you about the importance of complete and integrated public and private sector reporting into the national surveillance systems for malaria elimination. And we're going to use the Greater Mekong sub-region because it has some specificities, and the Mekong sub-region also is aiming to achieve elimination. So basically, I'll be talking about the background on why there's a plan for elimination in the Mekong, what's the current situation there, the importance of achieving universal access to malaria commodities and services, the methods to achieve universal access, and the importance of looking beyond the public sector. And then I will talk about strengthening surveillance for elimination and the case for why we need integrated surveillance. Many of you know that the Mekong today is a unique area in the world. And if you don't know where the Mekong is, it's Southeast Asia. It includes the countries of Myanmar, Thailand, Cambodia, Laos, Vietnam, and the Yunnan province of China. And this area gets its name out of the Mekong River, which is one of the longest rivers in Asia. What's unique about the Mekong is that there is the unique challenge of falciparum parasites having partial resistance to artemisinin, and also, importantly, resistance to the partner drugs of the artemisinin combination therapies. So if you look at today's resistance scenario, in many countries, we have resistance to 1, 2, 3, or even 4 artemisinin combination therapies that are currently available globally. And that makes it, then you are left with very few choices on what you can use to treat malaria in primary healthcare settings, as one after another, your ACTs start failing. So this is not a new problem. The Mekong has experienced resistance to antimalarials from the 1960s, early on with chloroquine and subsequently with artemisinin and the other antimalarials that are used to partner the ACTs. The first formal response, organized formal response, was in the form of the emergency response to artemisinin, which was launched by WHO in 2012 across the Mekong. That effort, which went on to 2015, demonstrated, while it was significantly successful, it demonstrated the fact that we are not going to be successful in addressing completely the challenge of resistance. And after a very detailed review of the situation, it was concluded that the only solution would be elimination. And so in 2015, the plan for elimination of malaria from the Greater Mekong sub-region was developed jointly with the countries of the Mekong and WHO. This was endorsed at the World Health Assembly. And this has been implemented since 2015. And still, although we've shown success, we still have quite a few challenges, and recognizing this, the ministers of the Greater Mekong sub-region, as recently as in May this year, issued a call asking for acceleration of that elimination effort, trying to achieve the targets of elimination before 2030. Now, the original plan, as you see, is 2015-2030. But concerned by the continuing presence of resistance, the ministers are now calling to see whether we can do something to accelerate that process even more. Because the earlier you do that, you are addressing a major cause for regional health security and global health security, and potentially preventing the further expansion of this problem of partial resistance to artemisinin and resistance to the other antimalarials. So, as I said, the efforts since the implementation of the emergency response in the Mekong have been singularly successful. If you look at the first graph on the chart, it shows the number of cases that are being reported, and there is a very significant decline in the number of cases over the last 6 years. Similarly, if you look at the number of deaths, a very significant number of decline in the number of deaths. We do have countries that have reached zero number of deaths. How does that translate into country-level data? And the combinations of parasite prevalences. So if you look at it, when we started off in 2012, our surveillance systems were not really good. So we simply had a lot of malaria, but we didn't know what it was. As we strengthened and invested in improving diagnostic capacities, we differentiated what types of malaria is there. And as the effort gained momentum, the problem of falciparum resistance was successfully being addressed. And so we saw a reduction in the proportion of falciparum and a gradual increase in the proportion of vivax infections. So reiterating again that the problem of resistance is in the falciparum parasites. And so what you're seeing, an increase in vivax proportion, while being a bad thing, is actually a good thing, if you really look at it in the context of the actual decreasing number of cases. And if you look at each of the countries, how are they performing? So the Yunnan province of China, and indeed the whole of China, has been a unique success story. Many of you know that the last indigenous case from China was reported in 2016, and we've had no indigenous transmission in China for the whole of 2017. And this is the 10th month of 2018. We are continuing with no indigenous transmission. So it is a unique success story. China is aiming to have formal certification by WHO in 2020. In Cambodia, the challenges have been more complex, largely because of challenges faced with implementing access to services. So we have, in Cambodia, about 50% of the cases are detected by the private sector and by volunteer networks. These networks have not been functional over the last several years due to challenges of financing. And the systems have been gradually coming into operation again, and you see a significant increase in the number of cases. In Cambodia, the number of cases in Laos have shown a significant decline, so have Thailand and Vietnam. The scale of decrease in Myanmar necessitated that I put it on a separate bar chart. And if you look at the parasite species, you see that in many situations, the proportion of vivax is gradually increasing, excluding in Laos. But here, the numbers have declined very significantly, and the malaria burden now is limited to 5 southern provinces, with nearly a 75% decline over the number of years that we've been looking at. If you look more detailed at where is the malaria, you find that the malaria burden tends to be now concentrated in largely along the national borders or in forests or forest fringe communities. Significantly important is the fact that nearly 90% of cases among all of the positive cases are among young adult males, and very few cases among females or children, reflecting the fact that we have actually managed to control transmission in villages and communities, but young males going into certain occupations or adopting certain behaviors are continuing to be exposed. And the nature of this also highlights the fact that this malaria is residual in these places because of the fact that in those areas they are exposed to increased biting, of course, but also it's linked to the fact that access to services and commodities are limited, and hence there is a need to actually address this problem and increase access. The limitations of access in the Mekong are not limited due to financial constraints. This is different from many parts of the world because of the problem of drug resistance. The Global Fund has established a special regional artemisinin initiative, which is about $240 million. And so it's not a financial issue that is limiting the options there. What is actually challenging is the actual delivery of services, interventions, and strengthening surveillance in these remote pockets where transmission continues to happen. The terrain, of course, is like in any tropical country. It's very difficult to access. And so it's not easy to get to these places and provide services to these populations who are scattered across these forest fringe areas. So how can we achieve access to these populations? How do we ensure there is enough adequate RDTs, ACTs, LLINs? There are several issues. With the ACTs, because of the rapidly evolving dynamics, the regulatory challenges of bringing new drugs, making them available at short notice is an issue. Convincing the manufacturers to make small quantities required for these low number of cases is another problem. But probably the biggest challenge is the fact that we're trying to achieve this universal access largely depending on a public sector. And although the money is there, the flexibility of thinking and operationalizing the approaches necessary, like using the informal private sector, using community-based approaches, is very limited. And so the expansion of services to these communities is very limited. So we have a challenge there, and this requires new thinking and boldness in operationalizing and accessing this funding and providing services. We have success stories, but they're limited in place and time, and that's indeed a challenge for us. So fundamentally, you've seen the maps, you've seen the charts, you've seen the parasite species. So we've done a lot in strengthening surveillance. And a lot of this data is now being generated to the regional data sharing platform, which is again an initiative that is managed by WHO but funded by the Global Fund's Regional Artemisinin Initiative. We use a DHIS2 platform there, and you will hear later about that because it's a wonderful open source platform which does not require a lot of resources, but also it facilitates integrated surveillance options, not only for malaria and not only for the malaria components of disease, vector, and services, but also for other diseases. So that's why we are using in the Western Pacific region and in the Mekong DHIS2 as an entry point for strengthening surveillance. We have standardized the data elements required for burden reduction and elimination across the region, and countries are progressing towards from burden reduction to elimination, and as they reach elimination thresholds to case-based surveillance. The regional data sharing platform, where it's actually working well, like in the Lao People's Democratic Republic, where they've adopted it as the national surveillance system now, already encompasses private sector data fully. So since June this year, all the private sector institution surveillance information is captured in Laos. In other countries, the progress is slower, but it is happening. The advantage of having something like DHIS2 is also that we recognize that as countries reach elimination thresholds, the funding is going to decrease, and malaria will move from being a vertical program to a program that is run through primary health care. And so having an integrated surveillance system where primary healthcare institutions, the private sector, the community can feed in information, and those sectors are equipped to deal with surveillance and response will make not only elimination during the last mile achievable, but also sustainable beyond elimination when it comes to the prevention of reintroduction, because at that stage, the funding is going to get limited. So WHO supports the establishment of integrated surveillance platforms and is encouraging countries to use the funding available with this opportunity now so that they prepare not only to accelerate progress towards elimination, but already prepare for the prevention of re-establishment of transmission in these countries. A lot of the information that I presented to you came from the National Malaria Control Programs of the GMS. A lot of the graphs, the data came from the Regional Data Sharing Platform, which is housed at the Mekong Malaria Elimination Initiative in the Country Office of WHO in Phnom Penh, Cambodia. I like to thank the staff of the National Malaria Control Programs, our WHO staff, donors and partners, and stakeholders who are actually contributing to facilitating this elimination process. And last but not least, I'd like to thank PSI for this opportunity. Thank you.
Great. Thank you very much, Dr. Rabe. Are there any questions? Please. And just identify yourself, please. Thank you.
Thank you for the great presentation. My name is Judy Wang from Global Health Supply Chain Program. So I noticed that you identify the challenge in terms of quantification of the medicines. And I'm wondering, in this region, most of the cases are around the border. So is there any possibility that this region, the countries in this region, would come up with a regional pool quantification across the borders so that, and you may also consider a pool procurement, because then you can group increase the volume, and that you may reduce the price. And you may be able to get suppliers more willing to support. And because this theme is about private sector, so I believe that if we consider that, you may have more engagement with the private sector.
Thank you for the question. Really good question. We are already actually working with the member states of the Mekong. We did a meeting in February this year, bringing in the regulatory bodies together. We are looking at a regional regulatory partnership that will help accelerate the process, but also the quantifications. The challenge is that the first-line drugs are different in different countries, and so you cannot use one drug. So the quantification still remains a challenge. The other challenge with quantification is that, like in Cambodia, part of that upsurge was due to stockouts, and that's because the stock estimations need to take into consideration the fact that we want to expand access. We want to get the drugs to places where they were never provided before. And so that quantification needs to be much larger than what they've been used to. If you don't do that accurately, you end up with stockouts.
Great. Any other questions? If not, Dr. Rabe, maybe I just have a quick question for you. In the Mekong, where transmission has dropped, you have foci that are, as you pointed out, kind of becoming more spread out and remote. And you talked about the importance of thinking about things differently, engaging not just the public sector, not just facility-based workers, community-based workers, the private sector. Is there any advice you'd have for those big burden countries that I mentioned, Nigeria, India, where they do have a very diverse, a lot of diversity in terms of the type of providers that are servicing the population, how to engage private sector providers and what their role looks like as transmission drops and you move from control to elimination?
Well, the real top burden countries, what we call the 10+1, the 10 African countries and India, which together contribute nearly 70% of the global malaria burden, they certainly need to think about expanding beyond the public sector. Where that should be primarily at this stage to reduce the burden. And when they are a few years down that path, they could then look at how they use the same mechanism to actually move towards elimination. But that discussion seems 10 years too early at this point.
Great. Thank you very much.